Hello and welcome to another video on chapter 38 where we're talking about alterations of digestive function. In this video we're going to talk about inflammatory bowel disease, diverticular disease, appendicitis, and mesenteric vascular insufficiency. So we'll start off with IBD, and that's really going to consist of ulcerative colitis and Crohn's disease. And these are going to be major types of chronic relapsing IBDs. We know that it's more prominent among the white population and Ashkenazi Jews. Now, we don't have a direct causation for these diseases, but we know that there are some theories, and they can include susceptible genes and also environmental factors or infections that could alter the barrier function of our mucosal epithelium within the intestines, causing a loss of immune tolerance to our normal intestinal antigens. So then our immune system is going to become activated and produce pro-inflammatory mediators that start to damage the intestinal epithelium. And this could also lead to a risk of colon cancer. So let's focus on ulcerative colitis first. And this is going to be a chronic inflammatory disease that's going to cause ulceration of the colonic mucosa. And we'll typically see that inflammation will take place in the sigmoid colon and the rectum, which is known as proctitis. And an interesting fact is that ulcerative colitis is less common in people who smoke. So I placed a article in our week 13 folder that takes a look at this, but essentially what that article says is that there is a complex relationship between smoking and ulcerative colitis, and that there may be some potential mechanisms there that are going to include changes in humoral and cellular immunity, cytokine and eicosanoid levels, gut motility, permeability, and blood flow that is going to change the colonic mucus, and also an interaction with oxygen-free radicals. So there's still more research to be done to kind of explain that. So if someone is developing ulcerative colitis, we're going to see that it will begin the primary lesion down here in the crypts, and the mucosa starts to become inflamed, and we get some small erosions, and you could see examples of this illustrated over here that then are going to get deeper and start to develop into ulcers. We can also have abscess formation and necrosis that can follow, and edema and a thickening of the muscularis mucosa that can start to narrow the lumen of the colon. That disruption of the mucosa can then cause bleeding and a cramping pain and an urge to defecate. So it's common to have bloody, mucousy, and watery diarrhea as a result. And like we said, this typically is going to take place in the rectum and the sigmoid colon, but it can extend to the entire colon, and there may be periods where we're switching from remission and exacerbation of this. So the symptoms are going to vary based on severity, but if it's in a severe form that involves the entire colon, it is called pancolitis, and we're going to see certain symptoms a bit more, such as abdominal pain, fever, elevated pulse, frequent diarrhea, about 10 to 20 stools per day, and we'll also feel urgency, obviously bloody stools, and that cramping pain that we mentioned. To diagnose this, we really use medical history, clinical manifestations, and laboratory serologic, imaging, endoscopic, and stool cultures to help rule out any other type of infection taking place, and biopsy findings. And for treatment, we need to individualize this. So we're going to see what the severity of the symptoms are and how much of the mucosa is involved in this. You could see some of that ulcerative mucosa here. Do we have the development of these pseudo polyps developing, and so forth? So in mild to moderate cases, we can give 5-amino salicylate therapy followed by steroids. And if it's severe, we can give some immunomodulatory agents or surgical resection as a last resort. And that could include a proctocolectomy or an ileal pouch, anal anastomosis. Now let's discuss Crohn's disease, and this is also known as granulomatous colitis or ileocolitis or regional enteritis. And it's going to be an idiopathic inflammatory disease that affects any part of the digestive system, anywhere from the mouth to the anus. So the risk factors here could include being a smoker, having a low fiber, high carbohydrate diet. Certain medications can also cause it to come about, such as taking NSAIDs, and having an altered intestinal microbiome. So we see some images here depicting what the intestines can look like after having Crohn's disease take place. Let's get into a bit more detail on that. So with pathophysiology of this, we start with inflammation of the intestinal submucosa. So that's our second layer of our GI tract, and it starts to spread with discontinuous transmural involvement. What that means is we can have these skip lesions take place, meaning that the inflammation is patchy and it's going to skip areas. So that's why we have these different areas kind of highlighted in red here, showing where the inflammation takes place, while other areas are going to remain unharmed. And we begin with a lesion as a granuloma, meaning a mass of inflammatory tissue, and it starts to become surrounded by ulceration. And then a fistula can form in the perianal area between loops of the intestines, or even extend into the bladder, rectum, or the vagina. We don't see it pictured here, but where we possibly may have narrowing of the intestines are called strictures, and that may promote obstruction taking place. And what is dissimilar to ulcerative colitis is if the client is a smoker, that's going to increase the severity of the disease and a poor response to treatment. So the symptoms are going to be pretty similar to ulcerative colitis. If you have a case study that talks about the location of where the inflammation is, that's a big clue. If it's in the rectum or sigmoid colon, or we could just call it the distal colon, you know that's going to be ulcerative colitis. Whereas if it's in the small intestines or it's skipping around the colon, that'll be a clue that it is Crohn's disease. But some other things that we need to know about symptoms for Crohn's disease is we may have no symptoms for years, but diarrhea will be one of the more common symptoms that may come about, and rectal bleeding if the colon is involved. Now, if the ileum is involved, so this part of the distal small intestines, then they may become anemic because this is where vitamin B12 is absorbed. So this could cause pernicious anemia, and it may also have a deficiency in vitamin D and folic acid, and also our proteins could be lost too, which could cause hypoalbuminemia. For treatment of Crohn's disease, it's going to be similar to ulcerative colitis, except for the fact that we want to stop smoking if we are a smoker, and we could take steroids, immunomodulators, anti-inflammatory drugs, and have surgery if necessary. And this really would be done to manage complications such as a fistula, abscess, or obstruction taking place. And we want to do routine colonoscopies to screen for cancer if we have a long-standing colonic disease. Next is microscopic colitis, and this is going to occur in patients that are older, and they may not have a history of alternating constipation and diarrhea, but all of a sudden we have this non-bloody diarrhea occurring, and when we look at the mucosa, it appears normal. But on microscopic evaluation, we could see that there are two forms. The first type is going to be our lymphocytic type of microscopic colitis. And if you look at the tissue here, you could see these more purple looking like dots in here, which are illustrating for us that we have increased intraepithelial lymphocytes within the wall of the colon. Then we have our collagenous form of microscopic colitis, and here we could see that we get a thickened subepithelial collagen layer, and we also see altered vascular mucosal patterns and mucosal nodularity. In both of these forms, we don't know what causes it, and our signs and symptoms can include abdominal pain and weight loss. And to treat it, we are going to try and use antidiarrheal agents to stop that daily watery diarrhea, and we could also use an oral steroid. On to irritable bowel syndrome. This is going to be a disorder of the brain-gut interaction, and it's characterized by recurrent abdominal pain with altered bowel habits. And it's quite prevalent worldwide. We see it in about 10 to 15% of the population, and we see that it's more common in women, and especially in the ages, in the youth ages and middle age. And we do see that people with the syndrome also have anxiety, depression, and a reduced quality of life. So the pathophysiology is unknown, and we don't really have any biomarkers for this disease, but what we do is take a look at how this syndrome is presenting. And I'm sure you can gather by the discussion we're about to have that this is a multi-system interaction. So we see visceral hypersensitivity or hyperalgesia, and this is really due to the dysregulation of that brain-gut axis. We see abnormal intestinal permeability, motility, and secretion, and this depends on the type of IBS that we have. In the next slide, we'll talk about how we have a diarrhea prominent one, a constipation prominent one, and an altering diarrhea and constipation form as well. So if we were to have more of a diarrhea predominant IBS, then we would have more rapid colonic transient times and increased intestinal permeability. If we are having signs and symptoms of bloating and constipation, then we can have delayed transient time and decreased permeability. And at times we can have a post-inflammatory, whether it's infectious or non-infectious type of IBS, and this could be due to, again, alterations within the gut microbiota and activating our immune system within the gut tissues and permeability changes. We can, like I said, have that alteration of the gut microbiota, and that seems to be influenced by sensory, motor, and immune systems of the gut that interacts with the higher brain centers. We can also have food allergies or intolerance, and this is when the food antigens activate the mucosal immune system, which then can alter intestinal flora, or the food antigens rather can alter the intestinal flora, or we can mediate the hypersensitivity reactions based on the food antigens as well. And then we've got some psychosocial factors, and this would include if the patient had early life trauma or abuse or emotional stress that interacts with the neuroendocrine and neuroimmune and autonomic nervous system, and also the pain modulatory responses. Now, we already mentioned some of these clinical manifestations, but they could be lower abdominal pain, discomfort, and bloating. And then we said we have 3 different forms that exist, and our symptoms are usually going to be relieved with defecation, and luckily it does not interfere with sleep. To diagnose this, we're going to look at the signs and symptoms and the personal history, and we want to rule out any other causes of these symptoms. And for treatment, unfortunately, there's no cure, and it seems to have to be more individualized. But we can, based on what symptoms are present, we can give laxatives and fiber, antidiarrheals, antispasmodics, pro-secretory drugs, low-dose antidepressants, visceral analgesics, and serotonin agonists or antagonists. And we can also use more holistic therapies too, like prebiotics or probiotics. We can do hypnosis, acupuncture, or yoga, cognitive behavioral therapy, or other dietary interventions. Now let's move into diverticular disease of the colon. Now when we talk about diverticula, you can see them pictured over here. They are describing these herniations of the mucosa through the muscle layers of the colon wall, especially in the area of the sigmoid colon. And so we have these 2 different terms that people tend to mix up with one another. Diverticulosis is really just describing these outpouchings, having many of them, but they don't really cause any symptoms, they just merely exist. And then we have diverticulitis, in which we can get an infection and inflammation taking place in diverticulosis. So even though we're identifying them here in the colon, they can really take place anywhere in our GI tract, but it's really rare to find it within the small intestines. Usually it's in the colon, and we're gonna find them in areas that are weak within our colon wall. The cause is unknown, but it is associated with increased intracolonic pressure, abnormal neuromuscular function, and alterations in intestinal motility. And those factors can be associated with the weak points, like we said, of that muscular layer. So I liked this illustration over here because we're going to see that it's also areas usually where the arteries are going to penetrate the tunica muscularis layer. And if you remember, that layer is made up of a circular layer and a longitudinal layer. So I don't have the circular layer pictured here, but we tend to find that that layer becomes thickened, and that is due to increased collagen and elastin deposits. And then we also see in the longitudinal layer, known as the Tennae coli, you see the 3 bands over here. And then if you remember seeing these in the cadaver lab, that's the Tennae coli right along there. It's really an incomplete longitudinal layer, and we start to see this layer shorten, and that causes the weak points that can then form the outpouching or the diverticula. Now, when we have complicated diverticulitis, we can have abscesses form, fistula, have obstruction of the colon, bleeding, or perforation, and the symptoms of uncomplicated diverticular disease may be vague or absent. So to diagnose this, usually we're kind of investigating some other disease process taking place, and we see it via ultrasound, sigmoidoscopy, or colonoscopy. And the treatment would be just to increase dietary fiber intake, resting the bowels, and having a clear liquid diet, and we can also use analgesics. And if we have diverticulitis taking place where we have an infection, then we of course want to take antibiotics. Now let's move into appendicitis, and this is going to be when we have inflammation of the vermiform appendix. Remember, we also saw this in lab. Here's our cecum, and then the appendix is coming off of that area. And this is actually one of the most common surgical emergencies of the abdomen. And it tends to take place between the ages of 10 and 19 years of age, but it could take place at any age, of course. And we're not really sure what causes it to happen, but there's a couple theories out there. The thought is that there is an obstruction in the lumen, and this could be due to something like a stool or tumor or even a foreign body, some type of obstruction, right? And that is blocking the drainage of the appendix. That then increases the pressure inside the appendix and decreases the mucosal blood flow. The appendix then is going to become hypoxic, an ulcer is going to form, and now bacteria can invade the tissue and cause inflammation and edema to take place. The signs and symptoms that we would see then is going to be epigastric or periumbilical pain. And I liked this illustration here by osmosis, which is illustrating for us where McBurney's point is. This corresponds to the location of the base of the appendix, and we can find where this is by placing our little finger of our one hand in the, there's my mouse, in the umbilicus, and then the thumb on that anterior superior iliac spine. And we find that point about 2/3 down from the navel to our ASIS. And we will feel tenderness or pain in 91% of the cases in which people have appendicitis. Now we also have some other diagnostic techniques here. Here's our rebound tenderness test. And this is a clinical sign in which there's pain. You kind of push on that area that we just discussed, and when we remove our hand, we are going to have pain take place in the abdomen. There's Rovsing sign, and that is when we are able to elicit pain in the right lower quadrant when we palpate pressure in the lower left quadrant. Another test we could do is psoas sign, and this is where we're going to have the patient lay on their left side and have them extend their right hip, or we can also have them flex the right hip against resistance, and that elicits right lower quadrant pain. And this would suggest that we have appendicitis. And then we have our obturator sign, and this is when we have the individual lay on their back and they flex their right knee to a 90-degree angle while the clinician internally rotates the hip or medially rotates the hip by moving the ankle away from the body. And so if we have pain, then it could be appendicitis once again. If we let too much time pass or we have complications, this appendicitis could cause perforation, peritonitis, and abscess formation. And for treatment, we want to use antibiotics and appendectomy, where we surgically remove the appendix. The last topic we're going to cover is mesenteric vascular insufficiency. And first, let's review the blood supply to the stomach and the intestines. So as far as our arteries, we have our celiac trunk, or some people refer to it as the celiac artery. We've got the branches coming off. If you remember, one of those branches is the left gastric artery to supply the stomach. And then we've also got the superior mesenteric artery that's going to supply the small intestines and the proximal portion of the colon, and then our inferior mesenteric artery that supplies the distal part of the colon. Now, once all of those organs receive their oxygenated blood, we need to drain that blood away, right? And remember, this is low oxygen but nutrient-rich blood coming from the stomach and intestines. And if you remember, we'll start here with our inferior mesenteric vein that's draining the distal colon into our splenic artery here, or I said artery, splenic vein here. And then that splenic vein is going to enter the hepatic portal vein, and we also see the superior mesenteric vein that is going to drain the small intestines and the proximal portion of the colon and enter into the hepatic portal vein. Keep this in mind for when we're going to discuss liver disorders in the next video. But for now, let's get back to our mesenteric vascular insufficiency. What does this mean? Essentially, it's a condition that develops when the arteries in the abdomen that's going to supply the intestines with blood becomes narrowed due to a buildup of plaque, but it really could be due to any type of condition that is going to disrupt the blood flow. So we see that some risk factors are going to be malignancies and right-sided heart failure and deep vein thrombosis. Mesenteric venous thrombosis is a type of mesenteric vascular insufficiency in which we have local blood coagulation that then impairs the venous return of the blood from the bowels. And then we have acute mesenteric artery insufficiency, and this is going to take place when we have a significant reduction in the mucosal blood flow to the small and the large intestines, and this could be caused by maybe a dissecting aortic aneurysm or arterial thrombus or an embolus. And then if we do have an embolus, we may have that embolus be caught more readily in the superior mesenteric because it's more in line with the aorta versus the inferior mesenteric. And then when that embolus gets stuck within the artery, it could cause ischemia and necrosis, which we would then call intestinal infarction. It's rare for this condition to become chronic, but we can get chronic mesenteric ischemia, and this tends to develop when we have atherosclerotic stenosis or occlusion, or it could be secondary to congestive heart failure, acute myocardial infarction, hemorrhage, thrombus formation, or like we've said, any condition that's going to impede that blood flow. And so when we're not getting blood flow to the organs here, we are going to get ischemia that develops, causing a cramping abdominal pain, which we call abdominal angina, and that is a cardinal symptom of this type of MVI. So our best way to diagnose this condition is to list out the clinical manifestations, look at laboratory findings and some imaging studies. And to treat it, we want to do aggressive rehydration and use antibiotics, anticoagulants, vasodilators, and inhibitors of reperfusion injury. It really depends on what the cause is. And then we may even need to do surgery if we see that some of the tissue has become necrotic.